You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for March 4th, 2022. This week, I want to update my CardioMEMS post from last week, ARBs and cancer, Troponins, empagliflozin, and low-value care. First, an update to my CardioMEMS post from last week. Last week, I presented on the GUIDE-HF trial and how it led to CardioMEMS FDA approval. I strongly opposed the approval. Today, I want to give a brief update on something that I did not make clear in that discussion. Now, if you haven't listened to last week, it would be useful now to go back and listen to the first 10 minutes. Here is the issue I was unclear on. The post-hoc pre-COVID analysis of GUIDE-HF, which the authors purported to show benefits for the CardioMEMS, actually and inadvertently strongly suggest performance bias, not actual efficacy, as the explanation for the finding. Let me explain. GUIDE-HF compared heart failure management with a PA monitor called CardioMEMS to standard care. The main analysis of the primary endpoint did not show a statistically significant reduction. But the pre-COVID analysis did meet statistical significance. Now, COVID-19 affected the follow-up of the GUIDE-HF trial. 28% of the follow-up occurred during the pandemic. The other 72% of the follow-up occurred before the pandemic. And to understand my argument here, I have to tell you the three components of the endpoint. The first component was mortality. Well, there's zero bias in mortality. The second component was urgent heart failure visits, which the authors describe as unscheduled and unplanned. This endpoint seems relatively low in bias too. But the third component was heart failure hospitalization, which of course is determined by a clinician who was aware of the treatment assignment. Now, this is a highly susceptible to bias. This isn't nefarious. It's just human clinicians acting like humans. Okay, now go to Table 2 in the Lancet paper. When you look at the pre-pandemic events, there were no differences in mortality or urgent unplanned heart failure visits. The clinician-determined heart failure hospitalizations is what drove the benefit. Heart failure hospitalizations were lower in the CardioMEMS arm. Now, was this a biased endpoint? Were clinicians more apt to hospitalize a control patient and less apt to hospitalize a device patient? Or was it perhaps the CardioMEMS was just a brilliant device? Now, to answer this question, you have to look at what happened during the pandemic. The authors don't tell us the event rates during the pandemic, but you can simply subtract pre-pandemic events from total events. Now, if you do this, you find that there were now no differences in any endpoint. Specifically, the lower rate of heart failure hospitalizations disappears during the pandemic. So is it clicking yet? Consider that during the pandemic, there was a high bar to admit patients to the hospital. You had to be sick. The pandemic essentially rendered heart failure hospitalizations a far less biased endpoint. And if heart failure hospitalizations was not a biased endpoint, say like urgent heart failure visits, and CardioMEMS actually reduced heart failure hospitalizations, you'd expect the same findings pre- and post-pandemic. But that is not what happened. Instead, during the pandemic, the device failed to reduce heart failure hospitalizations, which is especially weird because you'd expect the wirelessly transmitted data, which reduces in-person interactions, to be more beneficial during the pandemic. Now, what shocks me is that the FDA reviewers did not see this. This device is already likely to take off. It has a real chance of becoming the therapeutic fashion. I have a column that I'm working on these issues, and I often say in this podcast that I try to remain skeptical, not cynical, but stuff like this makes it harder. All right, next topic is ARBs and cancer. This is a real hot potato. There has been conflicting information about ARB use and cancer risk. 11 years ago, a group from Turkey published a meta-analysis suggesting an increase of cancer with ARB use. Subsequently, FDA reviewed the data and found no increased risk. Yet, senior FDA reviewer, Dr. Thomas Marciniak, who is now retired, had conducted his own individual patient-level meta-analysis and found an increased risk of lung cancer. Marciniak also noted problems with the original FDA review, including, for instance, not counting lung carcinoma as lung cancer. Now, numerous other meta-analyses outside the FDA have been published in the intervening decade, and the results of these have been mixed. Most recently, Dr. İlkay Sapaya, I'm sorry if I mispronounced that, he's from Turkey, and he was part of the original 2011 meta-analysis. He has published a single-author paper, another meta-analysis of ARB trials and cancer risk. The journal PLOS One published a paper. Now, the unique aspect of this most recent meta-analysis was that it looked specifically at cumulative exposure and cancer risk. And if ARBs do cause cancer, there should be a dose-response signal, namely more drug exposure. Higher dosages, longer duration should increase the risk. And one way to look at this question is to use what's called a meta-regression. This is where you plot the trials by cumulative exposure of the ARB on the x-axis, and then you plot the log risk ratio that the trial found on the y-axis. The trials with the greater exposure had the higher rates of cancer. Now, this was a trial-level meta-analysis, including 15 trials from the ARB trialist collaboration. There were about 75,000 patients and more than 170,000 person-years of exposure to high-dose ARBs. That's a lot of patients. And this paper found a highly significant correlation between the degree of cumulative exposure to ARBs and the risk of all cancers combined and also lung cancer. In trials where the cumulative exposure was greater than 3 years of exposure to daily high dose, there was a statistically significant increase in risk of all cancers combined. The increase in risk was 11%. This was highly statistically significant. Now, in trials with lower cumulative exposure to ARBs, there was not an increased risk of all cancers combined or lung cancer. And a cumulative exposure risk relationship with ARBs was independent of background ACE inhibition treatment. Now, these were not exactly small absolute risks. For instance, 120 patients needed to be treated with the maximal daily dose of an ARB for 4.7 years for one excess cancer diagnosis. And it's estimated that there's about 200 million individuals who are treated with an ARB globally. So obviously, there are public health implications as well. Okay, my comments. This is a super tough call. Journalist Sue Hughes has amazing news coverage. You should look at it. She has a detailed account of the findings and a great discussion with experts on both sides of this argument. I've exchanged emails with Dr. Franz Messerli and Dr. Thomas Marciniak. On the one hand, the most recent meta-analysis and meta-regression is worrisome. It comports well with Dr. Marciniak's initial meta-analysis in 2013. And the dose response here is compelling because if you posit this is a spurious finding, you say this is just post hoc cherry picking, then how exactly do you explain the dose response curve? Okay, another question that comes up is plausibility. Is it plausible that ARBs cause cancer or lung cancer specifically? Well, in his discussion of the recent paper, Dr. Sapaya spends many words speculating about the recent recalls of ARBs, as these were due to finding low levels of possible carcinogens in the compounds. I'm not as swayed by plausibility arguments, though, because if cancer risk is truly increased, the cause really doesn't matter. Now, I also find compelling the fact that Dr. Marciniak's and Sapaya's findings line up well. I'm not a statistician, but both look to be well-conducted analyses with pre-specified methods. Okay, that's the one argument that's the worrisome argument, but on the other hand, we also have to be fair about the limitations of this analysis. For instance, it used trial-level data, so it's hard to know things like smoking status and age. Though these are randomized trials, you'd expect randomization to mostly balance these covariates. I think the most compelling argument against the safety concern of ARBs is the one made by Dr. Franz Messerly and Andrew Althaus in Sue Hughes's news coverage. Namely, it's the matter of competing risks of death. That is, ARBs reduce cardiovascular events and prolong life. If you do that, you will see more cancer. For instance, when ARBs are used at high dose in patients with substantial heart disease or hypertension, if that reduces cardiovascular death, these patients will live longer and be able to get cancer and die of cancer. So, my friends, please pause here. Competing risks is such an important concept in the translation of medical evidence. We all have an expiration date. We are mortal. So if you treat older people and you reduce their death from one disease, say heart disease, these patients can live long enough to get another disease, cancer. I see this in my defibrillator clinic. Defibrillators in modern medical therapy has dramatically reduced the death from heart failure. Most of my patients with heart failure and ICDs live long enough to get other diseases like cancer. They would not be at risk for cancer if they have fatal VF or fatal stroke at an earlier age. Now, Andrew Althaus, who is a fantastic follow on Twitter, and we have actually co-authored a paper together, he points out that to sort out competing risks of death, you need individual patient-level data, which Dr. Sapali didn't have in the most recent meta-analysis. Here's what Althaus says. When there are some patients dying during the study, the only way to tell whether the intervention actually increase the risk of other health-related complications is to have an analysis that properly accounts for each patient's time at risk of the outcome. Finally, I do see a potential resolution to this issue. Sapaya wants FDA to restudy the issue. He points out that the FDA has patient-level data. So I kind of agree with him. Why not open this data up and let neutral scientists analyze it and then tell us the findings and how they went about analyzing the data. All right, next topic is troponins after cardiac surgery. The diagnosis of myocardial infarction entails three things. You all know this: chest pain, ECG changes, and enzyme rises. Cardiac surgery messes with each of these components. After heart surgery, all patients have chest pain and enzyme elevations, and nearly all have ECG changes. And as troponin assays get more sensitive, the question becomes what threshold of troponin or myocardial injury is high enough to predict poor outcomes, like, say, death at 30 days. The New England Journal has published an interesting observational study from the group at McMaster's looking at post-cardiac surgery, high-sensitivity troponin values and outcomes. This was an international prospective cohort study, including many different types of heart surgery. I'm sure they collected tons of data, but what they tell us in this paper is that high-sensitivity troponin I's were measured at 3 to 12 hours post-op, then days 1, 2, and 3. The authors then did some statistical analyses, regressions basically, looking at the relationship between peak troponin and death at 30 days. They included nearly 14,000 patients, of whom 2.1% died within a month. Here are the key findings. Among patients who had bypass or aortic valve replacement, the day 1 threshold troponin level that was associated with an adjusted hazard ratio of more than 1.00 for death at 30 days was 5670 nanograms per liter. Now that's a level 218 times the upper reference limit. Among patients who underwent other kinds of cardiac surgery, the corresponding threshold troponin level was even higher, and this is a level nearly 500 times the upper reference limit. Now, important in placing this in context is that troponin thresholds currently recommended in different consensus statements, say greater than 10 times the upper limit of normal, greater than 35 and 70 times the upper reference limit. These were exceeded in 97%, 89%, and 74% of patients respectively within the first day after surgery. So my comments here is I don't see this as that surprising. For instance, ablation causes troponin release. Cardioversion causes troponin release. Obviously, cardiac surgery is going to cause troponin release. Now, one thing is be wary of just the phrase troponin release. When you say troponin release, always think about myocardial injury. The question that this study gets to is that as troponin assays become more sensitive, we will have to adapt our upper limit of normals before making intervention decisions, say post-op angiography or stress testing or just more intensive follow-up. This paper does not tell us where to put those dichotomous limits, but it does tell us the current thresholds are way too low. I may be a bit old-fashioned, but I see tons of value in correlating troponins with other findings, especially in the post-op setting. Of course, the ECG is hard to use after heart surgery. There's usually a degree of pericarditis, but we can still look for focal findings. Sometimes a careful echocardiogram can help sort out a new wall motion abnormality. We shouldn't be nihilistic about using clinical criteria for diagnosing true post-op MI. Now, the other thing to say about troponin rises is that there are tons of causal factors. I can imagine a patient with CKD, COPD, severe LV dysfunction, who's operated on acutely is going to have high troponins, but is myocardial injury the only causal factor in that person's 30-day death? Now, the authors adjust for clinical scores, but is that enough to sort through the effects of every clinical factor? I don't know. I'm asking. Another concern I have with this paper is the 30-day mortality. Yes, this makes the study easier to do and it's clean, but what about 1 or 2 year mortality? Might there be a lower threshold for post-op troponins that predicts higher hazards at 1 to 2 years? Of course, there's going to be more noise when you use an endpoint 1 to 2 years out. Finally, I think this study has important implications for the interpretation of studies like the XL trial that compared PCI versus CABG in patients with left main disease. Remember that XL used a biomarker-heavy definition of MI. There were higher rates of MI after CABG, but later there were more MIs in the PCI arm. The criticism is that if one did not include these post-CABG MIs that were due to troponin rises, the rate of MIs would have been higher in the PCI arm. And since this was a component of the composite primary outcome, CABG would have looked even better than it did in the trial. Okay, next topic, FDA and empagliflozin. FDA has approved an expanded heart failure indication for the SGLT2 inhibitor empagliflozin, and it now includes heart failure with mid-range or preserved left ventricular ejection fraction. This is indeed an expanded indication as EMPA was already approved for use in patients with heart failure with reduced ejection fraction last August. Now we have 2 expensive drugs for heart failure with preserved ejection fraction, EMPA and sacubitril valsartan, approved on the basis of, I think, dubious trials. First, EMPA. Remember, EMPEROR preserved 6,000 patients with HFpEF. EMPA versus placebo, the primary endpoint was reduced by 21%. But the primary endpoint of CV death and heart failure hospitalization was driven only by heart failure hospitalizations. There was no change in CV death, all-cause death, composite renal outcome. And here's the kicker. That big reduction in heart failure hospitalization sounds great, but heart failure hospitalization accounted for only a tiny fraction of total hospitalizations. In fact, total hospitalizations did not differ. So what difference does it make if you don't reduce total hospitalizations? Now, I use SGLT2 inhibitors. I believe they are beneficial drugs for certain indications, but their use in patients with heart failure not due to a reduced EF seems like low-value care. Okay, now, sacubitril valsartan in HFpEF. Paragon HF, 4,800 patients with HFpEF. It was sacubitril valsartan versus valsartan. The primary endpoint was reduced by only 13%, and this did not reach statistical significance. Though, to be fair, the p-value was 0.06. But it's the same story as EMPA. The primary endpoint of CV death and heart failure events was driven by heart failure events, not CV death. There were no significant reductions in Paragon of CV death, all-cause death. Yet FDA approves the drug based on a subgroup analysis which suggested women and those with a low normal EF benefited more from the drug. Paragon authors don't tell us total hospitalization, so we can't assess how important the reduction in heart failure hospitalizations really are, but I suspect it's the same story as Emperor Preserved. Perhaps you've noticed a theme here: CardioMEMS, EMPA, sacubitril valsartan, and HFpEF. Each of these examples are new innovations that add little to progress. As we wrote in the Medical Conservative essay, quote, "To determine genuine progress, medical conservatives endorse evidence-based medicine and critical appraisal because many developments promoted as medical advances offer at best marginal benefits." Which brings me to the final topic today. The AHA, American Heart Association, has added another scientific statement about strategies to reduce low-value cardiovascular care. The first author is Dr. Vinay Kinney. They wrote that there is a critical need to reduce this kind of care, and they target examples in the paper like serial troponin testing in low-risk patients, routine stress after revascularization, CAC scores in patients who already have known heart disease, or say dual-chamber ICDs in patients without pacing indications. And one of the ways they suggest to reduce low-value care is to promote shared decisions with patients and nudges for doctors. Okay, let me make 3 comments about this paper. First, I think it's great that our leadership and professional societies recognize low-value care. That's a first step. Even if no one reads the details, it's great for clinicians to see leaders talking about low-value care. So kudos to the authors. My second comment is that we can all agree that the examples they show, the choosing wisely type things, are indeed super low-value care, but I would argue that these are not the main drivers of waste in our system. The main drivers of low-value care are the everyday, middle-of-the-curve things that have become therapeutic fashion. And you all know what they are. In my field, AF ablation done before risk factor management is now a norm, and it's low-value care. Left atrial appendage closure has become a norm, and it too is extremely low-value care. High-cost drugs like EMPA, sacubitril valsartan used in patients with HFpEF will soon become a norm, and I think that's going to be low-value care. The failure to critically appraise the normal stuff leads to far more waste than outliers like serial troponins. Okay, third comment. I want to strongly push back when people suggest that shared decision-making be used as a means to reduce low-value care. That is not what shared decision-making is for. While it may reduce low-value care, shared decision-making is simply the right thing to do. It's moral and ethical on its own grounds. Shared decision-making should not be used to nudge patients. It should be used to inform patients and increase their participation in medical decision-making. Reducing low-value care is on us, the clinicians, and the first step, I think, is not to be bamboozled by dubious evidence. And so that's it for this week in cardiology. As always, I'm grateful that you listened. And remember, friends, if you like this podcast, give us a comment, give us a rating. These things really help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.